This is lecture 9, elbow and radio-ulnar joints. We're going to do both the skeletal and muscular structures in this one lecture. This is a lovely stippled black and white drawing showing all the positions. You can see our radius is on the outside. This is the ulna that locks in with the humerus. Here's another view. You can see the radius does not touch the humerus. It's held together by a ligament, which we will look at. Hinge joint, single synovial capsule. Remember, we're talking about the elbow now. Humeral-ulnar, humeral-radial. Humeral-ulnar is the true hinge joint, good bony fit. The trochlear or semilunar notch of the ulna is surrounded by the trochlear condyle. You may not know what these are till we look. So, first thing is that we know for sure our elbow is not supposed to be sliding sideways. This design prevents lateral and medial slippage of the ulna. Can't push your arm, your forearm, lower arm back and forth sideways. And we are interested in this bottom section now. We looked at the top when we looked at the glenohumeral joint. Now we're looking at the bottom. This is the front. This is the back. Olecranon fossa. That's where the ulna fits in. The humeral radial joint is not really a joint. Can you see it's not connected? This dotted line is the capsule, and there's an annular ligament. We'll look at it more closely in a minute. There's no attachment. It's a condyloid joint. So, different view, you see it says annular ligament that holds the radius into the ulna. Now you can see the fossa. The olecranon process goes into the olecranon fossa to lock our elbow. There's another view, the front view. Now, interesting, our arm, even though it may look straight, is not. There's about a 15-degree lateral slant that's referred to as the carry angle. So what I did was I drew this blue line straight continuing, and then added the red line to line up with the actual longitudinal axis of the humerus. And that's the angle. And you ladies, because your pelvis is usually wider, there's a greater carry angle. That's just the design. Ligaments, we don't want our elbows to be traveling all over. Two large capsular ligaments. They're collateral on either side. Restrict side-to-side movement. That's the lateral collateral ligament on the outside. See that? And then, a black and white view of this is the lateral or radial collateral ligament. You can call it either one. We'll just call it the lateral collateral ligament. This is the medial collateral ligament. See that? You can also call it the ulnar collateral ligament. Movement angle of the elbow, 180 degrees, where we start, and we're moving in the sagittal plane. When we're in the standard anatomic position, bending our arms, we're in the sagittal plane. That's why we say that's defined in the standard anatomic position. Now, if you turn your arm out and then you bend your elbow, that's certainly not in the sagittal plane. But by definition, it's flexion and extension. Now, some people can go a little bit further. The hyperextension at the elbow. If you're all sitting in class, I'll have you lift your arm up. And some people have this. Now, what is the cause? Hyperextension of the elbow joint is not always present. When it is, it's around 5 degrees. So what anatomical features allow hyperextension at the elbow joint? What changes in the process and fossa allow this? So, olecranon process, olecranon fossa. That's what we're looking at. Here's the olecranon process, right? The pump at the end. Here's the fossa. on the humerus. If the process is shallow or less, and the fossa is deeper, our arm will go further. One more time. The length of the olecranon process, if that length is not as deep, not as pointed, and the fossa is deeper, this whole arm, the ulna, can travel further. So that's what makes people with hyperextended elbows. The radio-ulnar joints, they're named proximal, middle, and distal. And you will see the proximal one, of course, is not a real joint. The head of the radius articulates with the radial notch. And that's why we need the annular ligament, because it's not really touching. Can you see that? The radius pivots over, but it's not touching. So that joint is held together with the annular ligament. Stabilizes the radial head. That's where it is. The annular ligament. The middle is not a joint at all, but they call it because there's interosseous membrane in between. And the direction the fibers run upwards from the ulna to the radius. This is the ulna. This is the radius. The fibers run superiorly. Here's a cadaver. Can you see that? Now, why is that advantageous? I'll put the arrows in. For one thing, there's two reasons. The first is that when the fibers are angled up, it prevents the radius from traveling even further. The radius stays in place. Imagine if the fibers are pointing down, the radius can travel. So this prevents superior dislocation of the radius. Orientation have another biomechanical significance, and that is, what do we instinctively do when we fall to protect our body? We turn our palms in. So when falling face forwards, in what position do we instinctively place our hands to protect the rest of the body from impact? The reason is, if we supinate, that is, turn your hands out, these fibers get very tight. And if you have impact, they can tear. So we pronate to put some slack into these fibers. By pronating, the fibers are slack and it can absorb the kinetic energy. Slack fibers of the interosseous membrane during pronation better absorb the upward kinetic energy. So we do that instinctively. If we were to fall, and imagine this picture with our hands turned out, those fibers will be very tight and they can tear. And then, of course, the distal radio-ulnar joint, that's the radius, does connect with the bones of our wrist. And we will get to the wrist bones pretty soon. Connected to the carpals where the triangular disc, that's the ulna. The ulna does not directly connect. There's a disc. Movements of the radio-ulnar joint, we said pronation and supination. We already looked at these movements. In the standard anatomic position, the radio-ulnar joint is what? Supinated. And it said note pronation and supination can occur in different planes depending on the orientation of the humerus. So when the standard anatomic position was defined, you saw the palms facing forwards. And now we're ready for the muscles. Okay, the muscles of the elbow joint. We're going to look at the anterior muscles and then the posterior muscles. Biceps brachii, brachialis, brachioradialis. So there they are, colored. Let's look at the biceps first. We already did this when we looked at the shoulder, but let's look at it again because the major operation of the biceps is to work the elbow joint. There's a long head and a short head. It is origin of the long head, origin of the short head. Short head, very easy to see. Huh? So the insertion is down in our forearm, in the radius and the ulna. or the short head first, coracoid process. We can see that easily. The long head is the supraglenoid tubercle. So above the glenoid is a little bump. That's the supraglenoid tubercle. Notice the long head travels through the bicipital groove, and that can get irritated when we do certain things. Swimmers, paddlers, throwers, pitchers, notorious bicipital tendonitis. Tennis players. Insertion is the radial tuberosity. What does it do? Of course, flexion. And when we get to pronation and supination, you will see the biceps also helps with supination. So put your hand on your bicep and supinate. You can feel it tightening. So the biceps action is supination at the radio-ulnar joint. Muscular cutaneous nerve. Brachialis we don't see because it sits underneath the biceps. Large muscle lies beneath the biceps. See, brachialis. Origin, insertion. The origin is very easy to see. Distal half of the anterior surface of the humerus. The distal half of the anterior surface of the humerus. Coronoid process. That's on the ulna. It's from the textbook. Major flexure of the forearm. All positions that we assume with our elbow, our hand, the brachialis will work. Muscular cutaneous nerve. Now the last of the three, brachioradialis, superficial, palpated very easily, right on the top, right? Brachioradialis. This picture is a little exaggerated, but that's where it is. Origin and insertion. Now the origin is the distal 2/3 of the lateral, on the supracondylar ridge of the humerus, that ridge, supracondylar ridge, or condylar. Distal end of the radius. It goes all the way down to the end of the radius. Now that point is also called the styloid process of the radius. Elbow joint, action, flexors at the elbow joint, right? It's a flexor. Radial nerve. Now, all three muscles, as a general rule, act as third-class levers. We will cover the exceptions in biomechanics, 463. But as I said, as a general rule, all three of them are third-class levers because they insert away from the axis of rotation, which is the elbow joint. But it's important to know even at this stage that the recruitment, the contribution of each muscle in flexion depends on the starting elbow. The contribution of each muscle in flexion depends on the starting elbow and wrist positions. Depends on the position of the humerus and the radio-ulnar joint. The biceps is not as effective when held in pronation. So here's a very roughly drawn EMG recording, EMG, electromyogram. Supinated. Turn your hands out. Lots of activity of the biceps. Mid position, pronation. So where does this become really obvious? You're doing a pull-up. Pronation versus supination. You want to be counted, you want to do a pull-up contest, you will supinate because you're going to bring in your biceps, even though it may feel a little odd. We are much stronger with our muscles when the biceps comes into play in the pull-up. So supination is better. Now, the brachialis, thank goodness, is not affected at all by the radio-ulnar joint. It'll come, it'll work. But the brachioradialis is also very curious. Most effective in mid-position. You see that? So, people who want to work their brachioradialis do hammer curls, turning the dumbbell up vertically. Hammer curls. And again, it has some very important applications with throwing. We will cover that in 463. Now let's get to the back. There's the triceps and the adcuneus. 3 heads, triceps. We looked at the long head. We have a short head, a lateral head, and a medial head. So here's the long head. We looked at it before. Lateral and medial heads. So insertion is on the olecranon process. So long head, infraglenoid tubercle of the scapula. Okay. Lateral, posterior surface of the humerus. Medial, same thing. Posterior surface of the humerus. You can see that. This is all listed again from the book. Insertion is the olecranon process. Now, if you do too many push-ups or dips on the parallel bars, you might feel a little tenderness right there. That's because you pushed it too far. The olecranon process. That's the insertion of the triceps. Right there. Primary action of the triceps. Extension at the elbow. Chief extensor of the forearm. The long head, we're told, steadies the head of the humerus. Abducted humerus. That long head steadies the head of the humerus while the triceps are working. Cannot contribute to movements in the frontal or transverse planes because the line of pull of the triceps is very close to the axis of rotation. So primary work is in the sagittal plane. Radial nerve. And one more muscle helps us. We're not really aware of it because it's small. The anconeus. Origin is the lateral epicondyle. Insertion is the olecranon and the posterior surface of the ulna. So here's the olecranon. Right here. Posterior surface of the ulna. Assists the triceps in extending the forearm. Stabilizes the elbow. Now, anatomists also refer to the anconeus as a dynamic ligament because it really doesn't do a huge amount of force. That's why they call it a dynamic ligament. Radial nerve. And now we're going to look at the last set, which are the muscles of the radio-ulnar joint. Where would the pronating and supinating muscles be located with respect to the forearm? So the first thing is to realize that if you want to pronate, these muscles are in the front. Posterior, we used to use the supinators. There are 2 of each, pronator teres, pronator quadratus, for pronating. Now keep in mind that ulna is the stable bone. The radius pivots over the ulna. So the muscles controlling the movement must attach proximally to the ulna, distally to the radius. The radius pivots medially over the ulna in pronation, right? The radius in pronation. So here's the first, pronator teres. Now the pronators are all on the medial side. Medial epicondyle and coronoid process. Right here, coronoid process down here. This is the medial epicondyle of the humerus. Insertion in the middle of the lateral surface of the radius. So it's going to pull and help us pronate right there. This is pronator teres. This picture also shows the other pronator, which we'll talk about right now. First of all, let's say pronator teres pronates and flexes the forearm. Median nerve. The other pronator is way down by our wrist, pronator quadratus. It's called quadratus because it really looks like a quadrangle, right? 4 sides. What bone provides anchoring for the muscle? Remember, it's the ulna that anchors. So the pronator quadratus pulls the lateral edge of the radius to pivot over the ulna. Origin, remember this is the ulna. That's what stable bone. The radius pivots over it. Insertion. So, origin, distal quarter of the anterior surface of the ulna. Insertion, right across on the radius. We're looking here now, down here, pronator quadratus. Pronates the forearm, and it helps bind the radius and ulna together. Interosseous nerve coming from the median nerve. Now let's go to the back. Supinating muscles. We know one already. So the big one that we haven't covered is the supinator. Turning our arm out. Supinator. Okay, so here's the origin and insertion. Origin is the lateral epicondyle of the humerus. It also attaches to the annular ligament and the crest of the ulna, right here. But lateral epicondyle. Insertion, lateral and posterior anterior surfaces of the proximal radius, proximal 1/3 of the radius, right here. Remember, it's going to be wrap all around because it's going to turn the hand out. Supinates the forearm. Radial nerve. Now the biceps, just, you know this, but do it for yourself. The more we bend our arm, elbow, the more we can turn our radio-ulnar joint. So that's what we're saying here. Contribution of the bicep for supination more noticeable with 90-degree elbow flexion. Okay, so the more we bend our elbows, the more we can turn our hand out. Now the last couple of points here, we're going to talk about things that can go wrong, very common. It's called tennis elbow, but you can get it with other sports, of course. Common problem involving extensor digitorum muscles. It's also known as lateral epicondylitis. What's going on here? The lateral epicondylitis, that's where you feel it, right here. You see that? The lateral epicondylitis. All the tendons, everything starts to start feeling very, very sore. Lateral epicondylitis. When we pronate, right? Medial epicondylitis is when we turn our hand out like that. You see how the medial epicondyle really gets stretched? So when they say it's not very common, it all depends on the sport. Right? It's very common. Baseball pitchers, tennis players, turning your hands out. Water polo players, because they have to cock their hand before they throw, that area gets very sore. So that's called medial epicondylitis, the inside. And that is the end of the lecture.